Welcome to Management of Alcohol Use Disorder. My name is Kate Marshall. So to start with, I have no financial relationships or conflicts of interest to disclose. The opinions and guidance here are my own and don't represent those of any particular organization or entity. Cases have been modified and fictitious names used. Our objectives today are first to identify what is high-risk drinking, to identify whether your patient might be a candidate for ambulatory alcohol withdrawal management, to differentiate between alcoholic hallucinosis, delirium tremens, Wernicke encephalopathy, and Korsakoff syndrome, to list some treatment resources for a patient with alcohol use disorder, and to list the 3 FDA-approved medications for treatment of alcohol use disorder, as well as 2 off-label medication options. Before we get started, I want to review some brief but really critical concepts in substance use disorders care. First off, remember that substance use disorders develop when a brain that's been made vulnerable by either heredity, stress, trauma, or a crucial period in development is then repeatedly exposed to a substance that produces significant reward. The brain then encodes that substance as necessary to survival, and behavior changes to reflect that. We know that about 10 to 20% of the population has an active substance use disorder, and that's not including tobacco. We do know that substance use disorders are chronic, relapsing, and highly treatable. And we know that using appropriate language in care, such as avoiding terms like addict, abuser, dirty, they improve the quality of care for our patients and really helps them heal. So let's start with a case. This is Ralph. He's a 50-year-old man with a past medical history of hypertension and hyperlipidemia who presents to you for a primary care visit. Now, before we know anything else about him, my question for you is, what are the chances he has unhealthy alcohol use? Let's think for a moment about how much Americans drink. Binge alcohol use is defined as drinking 5 or more standard drinks for males or 4 or more standard drinks for females on one occasion on at least one day in the past 30 days. Turns out that 24% of adult Americans had at least one of these binge drinking episodes in the last 30 days. 10% of adult Americans meet criteria for alcohol use disorder by the DSM-5, and yet less than 1% received any treatment for alcohol use disorder in the last year. So you can see that there's a pretty large gap between disease prevalence and treatment incidence. As we consider how much our patients are actually drinking, we need to know what is a standard drink. So it's about 12 fluid ounces of regular beer, or a regular can of beer, about 8 to 9 fluid ounces of malt liquor, which has a slightly higher alcohol concentration, about 5 fluid ounces of table wine, which has even higher alcohol concentration, and then just 1.5 fluid ounces or a shot of distilled spirits such as gin, rum, tequila, vodka, whiskey, etc. When we look at high-risk alcohol use, we can define that as either exceeding a certain amount in one sitting or a certain amount per week. And it's recommended that women don't consume more than 3 standard drinks a day or sitting, or 4 in a sitting for men. And a total weekly amount shouldn't exceed 7 drinks for women or 14 for men. Now, the reason the numbers are different for men and women have to do with volume of distribution. Women get more exposure per drink because they generally have smaller body size, and for men and women of the same body size, women tend to have more fat tissue where alcohol doesn't distribute, so there's a higher exposure there. As to how these recommendations were reached, according to T.K. Lee, who's director of the National Institute for Alcohol Abuse and Alcoholism, or the NIAAA, our reviewers have found that except for those individuals at identifiable risk, consuming 2 drinks per day for men and 1 drink per day for women is unlikely to cause problems. And that said, consumption of any level of alcohol is generally considered to be less healthy than consuming none, and any potential health benefits of alcohol are probably outweighed by its risks. It's also important to realize that people may underreport their drinking, not realizing that the drink they order may count as more than 1 standard drink. For example, a modern wine glass may hold up to 12 ounces, and if you fill that to the top, that's 2.5 standard drinks. A margarita usually has 2 to 3 shots, so that's 2 to 3 standard drinks. A 40-ounce beer would be a little over 3 standard drinks, and 40-ounce malt liquor may be as high as 8 standard drinks. When we look at populations, there are a few that have higher than average risk for alcohol use disorder, and I'll review some of those here. First of all, men have a higher rate of alcohol use disorder compared to women, though this gap is closing, and women have recently seen rising rates of alcohol-related complication and death as well. Alcohol use disorder is about 50% heritable, as shown in twin and adoption studies. So family history is important to consider as you assess your patient's risk. Those with a family history may also be more likely to have had childhood trauma, and having 4 or more adverse childhood experiences is a strong predictor of adult alcohol use disorder. Marginalized and minoritized groups may also have higher likelihood of disease, which may be associated with intergenerational socioeconomic disadvantage and even historically inflicted trauma. We've seen that a history of gastric bypass surgery significantly elevates the rate of alcohol use disorder, with risk rising 2 to 3 times above baseline starting 2 years after surgery. And finally, there's a significant association between anxiety and alcohol use disorder, though causality is not clear. So let's get back to Ralph. In his primary care visit, he screens positive for potentially unhealthy alcohol use on Audit C. Now, the Audit C is a validated short screening tool that has been shown to be more sensitive for potentially hazardous drinking than other tools such as CAGE, which you might have been trained in using. And on further questioning, you learn that he drinks a case of beer, so 24 12-ounce cans each day. You learn that he has a history of trauma, reporting that he started drinking while serving in the military, and that he feels it has gotten much worse since his divorce 2 years ago. You ask if he thinks alcohol was a factor in his divorce, and he says to hear her tell it was. You ask when was the last time he went more than a few days without any alcohol, and he says it's been more than 2 years because every time I try to cut back, my anxiety goes through the roof. Now, he lives alone. He avoids seeing his adult children because he doesn't want them to see him that way. And he has no history of withdrawal seizure in the past. So based on your discussion, you actually diagnose him with severe alcohol use disorder, according to DSM-5 criteria. And you see that his current medications are atenolol and rosuvastatin. Recent labs have a normal complete metabolic panel, except for an AST of 82, which is about 2 times the upper limit of normal. And he asks for help getting through withdrawal. So my question for you would be, is he a candidate for ambulatory alcohol withdrawal management? What do you think? Yes? No? Do you need more information? So let's talk about how to approach this when a patient is looking to stop their alcohol use, and especially if they're unwilling or unable to go to a dedicated program for medical management of their withdrawal. Can you help them get through withdrawal in the outpatient setting? Is that even safe? Well, there are a few guidelines out there to help us, including the ASAM 2020 guidelines and the American Academy of Family Physicians guideline, which I'll cite here. Now, there are several things to consider when deciding whether a patient is appropriate for ambulatory withdrawal management. The first is whether they've succeeded before, or whether, given the track record, outpatient management is unlikely to be successful this time. If they've had delirium tremens in the past or a withdrawal seizure, inpatient management is best. Long-term intake of more than 17 standard drinks a day predicts complicated withdrawal, so better to admit to inpatient if they've been having more than 17 beers, about 750 milliliters of hard liquor, so that's a fifth, or more than about 3 to 3.5 bottles of wine a day. And to safely take medication, they'll need stable housing and some social support, even if it's a friend to stay with for the week. Now, for the same reason, they shouldn't be taking other sedating medications or substances during their withdrawal management period. They shouldn't have a concurrent serious illness like heart disease, CHF, or advanced cirrhosis. You want to check labs and make sure their electrolytes and liver look okay before you start, and get an HCG in anyone who could become pregnant as well. And if they're currently experiencing serious withdrawal symptoms, inpatient management is best. As for how you do it, plan for 4 to 5 days of medication administration. Both benzodiazepine and gabapentin tapers have been shown to be effective for patients who qualify for outpatient management. Be sure to give thiamine and folic acid, and you'll need close attention during this period, so daily visits for vitals are ideal, but the check-ins can also be accomplished by phone with a reliable patient and caregiver. And if it's not going well, the patient remains agitated, has hallucinations, or is having trouble keeping medication down, the understanding should be that they present for admission. Here's a sample schedule for 3 different benzodiazepine tapers. You can find this with an internet search for AAFP, Outpatient Management of Alcohol Withdrawal Syndrome. Now, since you already know that Ralph has long-term intake of more than 17 standard drinks per day, you should be concerned that he's at risk for complicated withdrawal and needs medical monitoring during the process. So in this case, the answer would be no, he is not a candidate for ambulatory withdrawal management. In this case, you prescribe oral thiamine and folic acid and recommend that he cut back slowly or seek monitored inpatient detox. Now, Ralph is able to be admitted for managed withdrawal, but you receive a notification that shortly afterward he's been transferred to a local hospital for hallucinations refractory to chlordiazepoxide. On admission, he reports that his last drink was 72 hours ago. Records show he received 1,200 milligrams of chlordiazepoxide in the last 24 hours. He's oriented to himself and the situation, but not to place or date. He says, "I have no idea." He reports he's seeing lots of mice in the room. And on physical exam, he's diaphoretic, but his gait is stable and his extraocular movements are intact. So my question for you is, what is this syndrome? Is it uncomplicated withdrawal, alcoholic hallucinosis, delirium tremens, Wernicke encephalopathy, or Korsakoff syndrome? What do you think? So let's compare and contrast the syndromes so we can figure it out. First of all, uncomplicated withdrawal generally occurs between 6 hours and 2 days from the last drink. You might see tremor, anxiety, diaphoresis, nausea, and headache. With alcoholic hallucinosis, this generally occurs a little bit later, about 12 to 48 hours after the last drink. In this, you see hallucinations, but with the orientation and insight preserved. Delirium tremens is usually seen a little bit later, 48 to 96 hours from the last drink. And in this case, you're going to have disorientation, can be with or without hallucinations. And you'll also see this autonomic storm, so that's where you get tachycardia, diaphoresis, fever, possibly tremor. That's a pretty high-risk scenario. With Wernicke encephalopathy, you notice that it's acute onset that can occur at certain points during the withdrawal. You might see disorientation, agitation, cerebellar ataxia, and abnormal eye movements as your key indicators of Wernicke encephalopathy. And this should respond to thiamine in hours to days. Korsakoff syndrome, on the other hand, is chronic. You see anterograde and retrograde amnesia, but preserved attention and social behavior, so it can be hard to notice at first. And this is the one where you may or may not see confabulation, where people make up relatively believable stories that just aren't true. So in Ralph's case, I'd say he's most consistent with delirium tremens, given his hallucinations, his lack of orientation, and that he is diaphoretic, indicating that he may have an oncoming autonomic storm. And if you're at all concerned about mental status, it's really not unreasonable to give IV thiamine. So 500 milligrams 3 times a day for 2 days, then 250 milligrams IV or IM daily for 5 days. In the hospital, Ralph is treated with phenobarbital and symptom-triggered lorazepam for his refractory withdrawal symptoms and receives IV thiamine for Wernicke's prophylaxis. 5 days later, he's nearing discharge, but he reports strong cravings for alcohol and difficulty sleeping. You consider whether a medication treatment would be indicated in this case, and my question for you is, which of the following is true? Medications for alcohol use disorder can only be prescribed by an addiction specialist. Medication treatment should be offered to all patients with moderate or severe alcohol use disorder. Patients cannot drink alcohol while taking medication treatment for alcohol use disorder. Which one rings true for you? First, let's review some options available for ongoing treatment of alcohol use disorder. Starting with medication treatment. This might be integrated with a primary care provider or as a referral to a specialist. Individual behavioral treatment can be either integrated with a primary care provider or a referral to a specialist as well. Group behavioral treatment may be integrated with a primary care provider or at a dedicated outpatient program. Mutual aid groups are in the community. These are things like Alcoholics Anonymous, Narcotics Anonymous, Smart Recovery, and Recovery Dharma. And then there's self-management, so primary care monitoring and brief counseling would be a minimum that was recommended for a patient with alcohol use disorder. When considering medication treatment, remember that medication treatment should be offered as standard of care to all individuals with moderate to severe alcohol use disorder who are currently drinking, recently abstinent and experiencing cravings, or who are at risk for a return to drinking, or who prefer medication along with or instead of a psychosocial intervention. Now, let's review the medication options we could consider in these cases. Here we see 5 potentially effective medication options for alcohol use disorder. Again, these should be offered to patients with moderate to severe use disorders. 2 of them are off-label and not FDA-approved for this purpose, and I've noted that there. First line is naltrexone. So for alcohol use disorder, there's evidence for either daily oral therapy or monthly long-acting injectable, also known by the brand name Vivitrol. Naltrexone is an opioid blocker, but the opioid receptor system is so involved in the brain's perception of reward that blocking those receptors can actually reduce alcohol cravings and decrease the reward people feel when they do drink. And the number needed to treat to prevent return to heavy drinking or return to any drinking is in the range of 12 to 20, so it's really quite effective. You should consider starting naltrexone if the patient is currently drinking or recently stopped, if their liver function tests are less than 5 times the upper limit of normal and they don't have any decompensated liver failure. And of course, be sure it's been at least 3 days and probably more like a week since their last opioid, and that no need for opioid therapy is anticipated. You'll want to monitor LFTs periodically and stop if elevation develops over 5 times the upper limit of normal for either AST or ALT. And common side effects include nausea, vomiting, headache, and dizziness, but are generally mild and subside with a temporary dose reduction. Next up is acamprosate. It acts on the glutamate and GABA systems to reduce the reward someone gets when they drink. This one really works best when someone has a couple of days of abstinence under their belt, and the number needed to treat for return to any drinking is about 12. It's kind of a pain to take since it's 2 big pills 3 times a day, but unlike naltrexone, it can be given to patients with hepatitis, decompensated cirrhosis, or who take opioids, including methadone or buprenorphine. Some folks might be able to take 3 pills twice a day if that makes it easier. Dose reduction is required in renal impairment, and it's contraindicated with a creatinine clearance of less than 30. The most common side effect is diarrhea, which again tends to improve with temporary dose reduction. Next, we have the classic disulfiram, also known as Antabuse. This one irreversibly inhibits enzymes used to metabolize alcohol, so ingesting alcohol causes severe flushing and nausea. It's rarely used anymore since no effect on drinking has been seen in settings where dosing isn't directly observed. And it has a host of very nasty potential side effects, lots of medication interactions, and can't be given if the patient has prior coronary artery disease, psychosis, or advanced liver disease. I've mostly seen this used when a patient has experience with it and wants to prepare themselves to resist drinking in a situation where they fear they might, where they're very self-motivated, but again, only very rarely. There is some evidence for off-label use of a couple of medications for alcohol use disorder as well. So meta-analyses on gabapentin for alcohol use disorder show an overall reduction in percentage of heavy drinking days, with greater effect at total daily doses over 1,800 milligrams. and gabapentin appears to be particularly helpful in patients who have a history of acute or post-acute alcohol withdrawal symptoms. And topiramate actually compares favorably to naltrexone and acamprosate in meta-analyses as well, and can be titrated up to as high as 300 milligrams if the patient can tolerate it without oversedation. So, to review, you've got several good options for medication treatment of alcohol use disorder that you can use, and in the case of naltrexone, can be started if the patient is still drinking. So, coming back to our question, we see that it's not true that medications for alcohol use disorder can only be prescribed by an addiction specialist. Primary care providers, internal medicine, general medicine, they can all prescribe. It is true that medication treatment should be offered to all patients with moderate or severe alcohol use disorder who don't have absolute contraindications, and those contraindications are rare. It is not true that patients cannot drink alcohol while taking medication treatment for alcohol use disorder. In fact, they can drink alcohol while taking naltrexone. So Ralph is seen 1 week later in primary care, and he's now taking naltrexone 50 milligrams daily. He's attending AA meetings every day and reports no return to use of alcohol since discharge from the hospital. So, in sum, today we learned how family history and trauma history are among the risk factors for developing an alcohol use disorder, how AAFP and ASAM both have helpful guidelines that can assist in identifying candidates for ambulatory alcohol withdrawal management, that alcohol hallucinosis, delirium tremens, Wernicke encephalopathy, and Korsakoff syndrome can be differentiated primarily based on timing and whether the patient has insight into their condition and is oriented. That resources for a patient with alcohol use disorder include medication, behavioral treatment, and mutual aid groups, and that the 3 FDA-approved medications for treatment of alcohol use disorder are naltrexone, acamprosate, and disulfiram, and that 2 off-label medication options are gabapentin and topiramate. Thank you.